Yeah, have you ever had a single patient, because we've all done a lot. I can tell you, all of us have done a lot. Have you ever had a single patient unhappy with the removal?
None.
Not a single one.
I've had one or two said, we should take a little more. It seems like there's a little asymmetry here.
But never has it been, you took too much. Welcome to HKB Uncut, the health, knowledge, and beauty podcast.
On this show, we unpack the newest techniques and trends in cosmetic surgery, how to tune out the social media noise to make empowered decisions about your appearance, and what you need to know before you book a procedure.
I'm Dr. Bill Kortesis.
And I'm Guarav Bahardi. We are board-certified plastic surgeons and co-founders of HKB Cosmetic Surgery, an award-winning practice with 11 locations across 6 states.
In other words, when it comes to aesthetics and cosmetic surgery, we've pretty much seen it all, and we want to share our knowledge and unique approach to aesthetics and beauty with you. Whether you're interested in cosmetic surgery for yourself or want to separate fact from fiction in the plastic surgery world, we hope you'll tune in each week.
Today, we're really excited to talk to our Department of Facial Plastic Surgeon leader, Dr. Richard Cow.
Love me some Dr. Cow. I'm excited to have you on the show, bud.
Thanks, guys. Appreciate being here. It's been great.
He's the cowboy, and for the girls, he's the cowgirl man.
Oh,
I don't know what you're talking about, but I would really like to dive in deep here.
Take a deep dive.
Intended on facelifts and all things facial surgery. Honestly, you've been a really big boost to the practice. We've enjoyed obviously getting to know you, being a colleague, and you taking care of all these wonderful patients. But gee, I really want to dive in deep on these facelifts. And I think the first thing I want to hear, because everybody's talking about it, deep plane facelifts. Yeah. Should we do it? Should we not do it? Is it just, a fad or trend, or is it here to stay? And what are the advantages, disadvantages, and why would somebody do deep plane versus traditional?
Yeah, and I think this has been kind of present the entirety of my career here, certainly, is talking to everybody. The patients ask about what the deep plane facelift is and what's involved with that. And, it does take time, but I think it's worth kind of explaining to them, like, the reasons why we do it and the risks associated with that. I think these days it's kind of just thrown around a lot too, like, oh, I'm doing this. Are you really doing all the surgery that's entailed with a deep plane facelift and neck lift and so forth? But, I think it always starts with talking about the retaining ligaments of the face, which are in the SMAS, underneath the SMAS, I should say, and releasing those ligaments in the cheek by the masseters, the retaining ligaments in the neck, and then certainly the mandibular cutaneous units too. So these are the areas that are important to release, actually get you that nice elevation of the fat pads, help smooth out those nasolabial folds.
So for all the laymen out there, when you're talking about the retaining ligaments and these structures in the face, let's talk, specifically, what are you referring to, and what does that mean to somebody coming in kind of layman's terms?
Yeah, it's tough. Sometimes patients already come in and they're already honed in on the questions of what are the retaining ligaments of the face.
Let's start like you're talking to Dr. Barty, who doesn't know a whole lot about the subject. But no, let's
accurate.
But let's start with somebody who doesn't know a whole lot, and then let's kind of fast forward to kind of the more advanced stuff.
So facelifts and even deep plane facelifts have been around for a really long time. That's actually the truth of the matter. And so we have the skin, obviously, of the face and the neck. And then as you go deeper, the SMAS layer, the superficial muscular aponeurotic system, that's actually the next layer, the SMAS. Underneath that, you have the other tissues of the face and the neck, right? So you have other fascial layers, you have deeper musculature of the face and neck. So for facelifts, when we are these days, usually somebody's doing something to the SMAS layer, which is the layer that's underneath the skin. Okay, so obviously different methods to perform facelifts. With the deep plane, you're actually going underneath that SMAS layer, underneath the platysma, and lifting the units of the skin and the SMAS and the platysma together. And so, the idea behind that is a couple different things. For one, does it give you a longer lasting result? I think the answer there is it certainly can. You're releasing a lot of those areas that we just discussed, the retaining ligaments, and that can help give you a nice smoother approach, smoother results. Also, it gives better vasculature. So it maintains the vasculature to the skin, and you should have a, better result overall, less issues of scarring overall, and, tissue loss and kind of the unfortunate things that can happen if you stretch the skin too tight.
That's a great point that you make, and is to remember, like, some of the initial facelifts that were first described and done were, skin was loose, things have dropped, pull on the skin. When we all have learned that, skin is just not sufficient, right? And you have to handle kind of the underlying soft tissue network, and then there was this kind of movement towards okay, so you move the skin and you move some of that deep underlying soft tissue network, but as you're describing these ligaments and releasing those ligaments, that leads to better excursion, better movement of all this kind of facial construct. So you literally take what's dropped down and you all are able to reposition it to where it should be. And then the skin just follows, right? The thing is, it's sort of a skin surgery, but it's not really a skin surgery in and of itself. So I think that's a big thing that, a deep plane approach and some other approaches can afford patients.
Yeah.
One of the things that I get asked about, and I know me and you've had this discussion, but I'd love to get your thoughts on this, on the philosophy of like, all right, so this is a super popular procedure now.
Yeah.
It's always been a popular procedure.
Yeah.
When should a patient start thinking about it? Should they come see you at 35, 40, or should they just do fillers and Botox and just wait till they're 50 or 60?
Yeah, and I think that, for all of us that have been practicing for some time now, man, it's so hard to put a certain number on when someone's appropriate. I just talked to somebody the other day, massive weight loss patient, 32 years old, and you're sitting there looking at her, you're like, yeah, I actually think you would actually benefit. That's something that I never honestly imagined prior to working here and in this current, 2026 era of massive weight loss, GLP-1s, et cetera. But that's the reality of it. And then other times, I'm seeing patients in their like 80s, and I'm like, well, yeah, we could definitely do something here to help you, but you don't have the worst findings. Maybe we work on your skin, do the other things. Naturally, at the older age, you're gonna have some volume loss, reposition those tissues as well. But yeah, it's becoming less and less a number. I don't know what you guys think about it, but that's my practice has definitely shifted. Certainly younger with respect to considering facelifts, which has been crazy.
I think the trend is to do it sooner. I think a lot of patients don't necessarily want to wait till things are too far gone. And then they look back and go, wow, what a dramatic difference. I think people don't want to age gracefully. I mean, they really want to age not at all, right? And reversing.
You want to like preserve your prime. You know what I mean? It's like you're at a place you just want to stay there. And like the truth is, I don't know about you all, the facelifts that you do and we do, the patients look elegant and natural. If someone's trying to get like a lift result or a volumization result, if you're too heavy-handed with, fillers and neuromodulator,
it doesn't look natural.
You get a look. Now listen, you can do filler in an amazing way. And our injectors can do some amazing things with fillers and biostimulators. So I'm not knocking them at all. Matter of fact, they're very important, and actually they can be used with, facelifting procedures subsequently. But like the results, are just better. Like facelift results are awesome. I'm gonna get a facelift. I don't know about you.
It's in my future for sure.
There, right? I'm kidding. But like at some point, like it's not a bad surgery. Like I'm gonna ask you, you do a ton of facelifts. You're gonna get a facelift?
If it's the time, it's the time. I have patients all the time ask if I'm 14 years old, so it's hard to kind of
he does look freakishly
tell people to I'm almost
Doogie Howser
your age or something. But what I'm also finding, there is some benefit to having a lot of information out there now as far as facelifts go. Obviously, the celebrities doing it too, and I'm sure we'll talk about that. But there's just more awareness of it, and I feel like the population, the generation, I guess, of people in their 40s currently and, so forth, they are more comfortable with it. And they know what to expect. And like you said, they're going to heal best right now. They don't want that change where they can't recognize themselves or, they just want to be in their prime. Maybe they have social things that they want to, perk up for or whatever the word is. But it's been awesome. These are some of the most rewarding patients for sure.
How do you talk to patients about the fact that they're unhappy with how they look? They're already starting to see laxity in their neck and their jowls. They're scared of facelift. They come in talking about non-invasive stuff or minimally invasive. like Elicor, Skin Tightening, Renuvion, which are all great devices. But how do you differentiate between who's going to be needs to go down the road of a surgical candidate versus, hey, I'm okay doing these minimally invasive stuff?
Yeah. And I think this matters a lot, your conversation with them, understanding their motivations and the kind of results that they're looking for. We do a lot of Elicor here, obviously, and the other non-invasive or minimally invasive things as well. Yes, it's natural for people even in their 30s to start noticing some laxity, especially a lot of women, they've had kids and kind of lose a little bit of volume here and there, or others are kind of noticing a little more hanging of tissue, in their jowls and their cheeks. So I think that, you definitely want to understand their goals and understand if they want, more definitive change, doing a surgery that for one time might actually give them that result they're looking for, a more, significant amount of change. If you're doing non-surgical stuff, obviously sometimes it takes multiple sessions. I mean, all these products are sold to us and, we got to do multiple sessions of them. So they have multiple downtimes, and that's not all bad. If it suits their lifestyle, that's a good thing for them to pursue. But I try to just tell them, look, like, there are things like that I do recommend. If you do just have a little bit of neck skin laxity, Elicor could be a great option. Radio frequency microneedling can also be a great option for those people too. Certainly lasers have a role. And then, just kind of small stuff, right? Like volume. We talk about fat grafting today. I just did a case today where we did fat grafting on somebody who I didn't feel like was quite ready for a facelift per se. Just had some volume loss over time. So just giving them different options. And I think they'll be good. I think these are all intended to kind of buy them some time before they're maybe more ready for, the big surgery.
One of the things that I know when I see you doing a facelift, or you're doing a facelift, or I'm doing a facelift, like very rarely is it just a facelift, right? And so there are often other interventions that are being done simultaneously. There might be just one thing, or there might be multiple things. Walk us through why it's super valuable to consider combination interventions when approaching the face in general, and how that. I mean, is that going to make them look more operated on, or they actually look better? Like, what's your philosophy on facial rejuvenation from a surgical standpoint? Like, what do you do? What do you look at? How do you, explain to a patient, like, all right, yeah, you're coming in for this, but, what about the rest of this?
Yeah. It's funny. Sometimes patients come in and they say, all I want done is my neck. And I'm like, that's it. And you start pointing different things out, not to kind of make them think that they need to do these things, but you also show them, well, you do have some jowls, and then, you have some hollowness around the eyes, or maybe you have excess hooding around the eyes. And whether or not these things bother the patient, I think that's the first thing to ask about, is like, are these things bothering you? But when patients often say, I just feel tired. So you really have to peel through that. Mm-hmm. And then when you peel through that, kind of feel tired, just don't feel the same, I don't look the same anymore. That's when I think you actually have to address so many more things. And that can be kind of like overwhelming for some people if they're not ready to kind of like embark upon doing eyelids, brows, fat transfer, facelift, neck lift, whatever it might be. But, I try to tell them, look, you can certainly split some of these things up if you don't really feel like you want to do them all at once. And there's reasons for that. Sometimes they have concerns over general anesthesia, even though we have a great facility here. We have, multiple surgeons, multiple anesthesiologists, et cetera. So it's a super safe place to do surgery, actually. And, one of the best parts. But, I think it really depends on the kind of downtime that they're expecting. And, what's funny is, like, with the facelift specifically, there are certainly some, like, swelling, bruising to encounter. But I feel like sometimes with things that they might think are smaller, lower eyelid surgery, you can definitely see a lot of bruising with those kind of procedures too, unfortunately. So sometimes it does make more sense to put it all together so you kind of get that done.
Recovery.
Yeah. But, I think everybody has a different approach with that.
Yeah. One of the things you and I have talked about when you're approaching the face, if you're going to look, and Bill and I have talked about this for the body, like when we talk about somebody, when they come in for a tummy tuck, like you see their anterior part of their torso, but when we see them, we see them all in 360. So it's like same with us. When we see somebody's face, you're not looking at binoculars just at their, lower face and neck, or just their eyes. Yeah. And so it's interesting when you approach it kind of as a pan-facial thing and do multiple little things. And even, you're a big proponent of CO2 laser as well. And maybe we can chat about that. But like, it has a unique effect. So when they come back in, their face is in kind of harmony. And I don't know about you, but every time I'd love you to tell us like your patients' reactions when they come in, like 2 weeks or 4 weeks afterwards. Like, what are they like? Like, what are
Yeah.
these patients like?
Yeah, the vast majority of them after 2 weeks, we've all their sutures are removed at that point. I think they're all pretty much free to do mostly what they need to do. You know what I mean? Our incisions heal really well. They're not dealing with kind of really bad scarring at that point. I tell most patients by like, I don't know what you guys say, but after that 2 week period, life just gets a lot more normal. By 4 weeks, you should really be pretty prepared for an event or like go out and things like that, and not feel like you're going to be like stared at or anything.
What are their comments to you when they come in? Their swellings are gone.
Yeah,
Some of
I
the words
mean,
that use.
the most common things, obviously, I think this is, like I should have done this earlier. I really felt like the swelling would last longer. I didn't think it would be this easy. I didn't think it'd be this painless. I didn't need to take any pain medication. A lot of our patients, these days are not trying to take a lot of narcotics anyway, but yeah, the recovery is overall pretty fast. And I think what really helps is like being aware. Obviously, it's our job to kind of educate them, but also like I really talk to the patients like, really have faith in the process, like be positive and know that, I just talked to a patient today, like you're going to be fine. You're going to do great. But we also have to be on the same page with that and know that we're going to take care of everything. And as it comes up, but the key is to kind of stay positive and know that you're going to look great.
It's always fun when you see patients. Like I've seen your patient. I've done some follow-ups for you, and I've seen our own. And then when they come in that 1 to 3 month to 6 month, even like a year out, and they're just happy. They come in to see you, and it's just like it's a fun social visit, and that you made that impactful change, and they look great. What about scar? How visible are these scars? Because I always feel like they're just. I mean, you really have to look.
Yeah.
But give us some of your thoughts and explain kind of scar and how disguised are they?
Most of the facelift scars are kind of hidden in shadows, right? And by the hairline, so I position it in the hairline itself. As it's healing, the scar will usually kind of, the hair is going to heal through the scar itself, so kind of further obscures things. And then it travels along the ear, a little bit of area right there in front of the helix, root of the helix there, which is, a fancy word for in front of the ear. Then I usually go behind the tragus. I know there's some people who like to go in front of the tragus, which is this little area here, and then behind the earlobe. So essentially all this stuff is hidden, in most women, I should say. So when you have your hair down, obviously they won't see anything. But I find that our incisions heal super well. We get them on the right regimen. You're not pulling too tight, et cetera, on the skin. So scar is definitely one of the most common questions for sure. Like, are you going to be able to see? Are you going to be able to tell? I think if we're taking care of the tissues properly, during surgery, not putting things under tension too much, you should have a really nice, nearly invisible scar once you're all healed up. I mean, we also do things like lasers and things like that if we need to kind of further augment things, make it even more invisible, which, takes a few efforts sometimes, but it's definitely worth it.
And what about, someone who's had a facelift 10, 15 years ago? I mean, are they hosed? There's nothing to do? Are they going to look like if they have something else done, are they going to have a negative outcome? I think it's a misconception. Walk us through secondary, tertiary, quaternary facelifts, because I know you've done them all.
These days, it's like, I feel like half of our patients have had some form of facelift done in the past. And look, that's just kind of the time course, right? We're all aging even at the time of surgery. We're healed up, but then in a number of years, you're going to have signs of facial aging. This is normal. So no, you're definitely not hosed if you've had a previous surgery and you want to have further improvement. We see this all the time, and I think it's actually important to kind of like, we have to accept that too, because moving forward, if people are starting to do this younger, we're just going to have to get better and understand where we are in the anatomy and what the prior procedures were, to really give them the results that we want, second surgery, third surgery, and so forth.
How long will it last?
Yeah.
A patient comes in, they have their first procedure done. And they always ask, how long is it going to last?
Always ask that. They really do. Yeah. And I mean, the studies, that have been shown, it's like 8-10 years is the idea here. And I think often patients, when we do surgery on them, especially when you combine the other things we were kind of talking about before, sometimes they feel like they're younger, 15, for sure, 20 years. Yeah. I don't make these numbers up. They're the ones saying it. So I think that's a pretty great return on, if you're calling it a 8-10 year surgery and you feel like you wind it back 15 years, that's great.
Yeah, that's usually what I tell them. It's like, we're just turning the clock back, but the aging process will continue. Is there anything that you see or that patients have done previously that make a facelift more difficult, that you would, knowing what you know now, would tell patients, hey, think about this before you do it? I know a few that you're going to say, but I think this is a key point that a lot of patients are really going to want to hone in on, of things to avoid to make your facelift better in the future.
Yeah. So maybe the most important thing I think is timing. So doing some procedures, if it's within 3-6 months, I really don't think that's a great idea. Even something as minor as certain lasers, I would say, are not a great idea. I've done some facelifts on people that had laser within a 3-month span, and maybe we didn't do it, in our practice. But like when you're dissecting that tissue, trust me, like this is why I know lasers work, is because you can see that change in the skin. You can tell in the areas that they didn't touch, like, wow, this is elevating just fine. That collagen production is real, and it certainly can, disrupt the planes. But, we are experienced surgeons and we're able to get through it. It's just knowing about the timing. So I generally try to tell patients, like, look, like if you are planning having surgery, try to avoid things maybe up to even that year. And what I mean by that are things like, RF microneedling, more invasive things like face tight, if people are doing that at this point. Renuvion. I mean, ideally, these are not things you're doing in the months beforehand. Sculptra. Threads, certainly. So these things can be put in the, you try to put it in the right plane when people put these things, but sometimes they can get a little bit weird and cause some scarring, and that can certainly make, surgery more challenging. So yeah, it starts with timing. Now, I do have patients that have had these things done before, and I'm sure you guys have seen it when you've had surgery, and even surgery in someone facelift like 10, 15 years ago, usually by that point, that skin has remodeled pretty nicely. So when you're elevating things and, if that SMAS layer is still intact and things like that, it's really not that bad. So if someone's really like maybe not a surgical candidate, I think doing non-surgical stuff is actually great. You're not going to disrupt anything. But yeah, I would avoid doing it too soon prior to surgery. I think that's the key.
Yeah, and also, I think one of the things is it's great when like as a surgeon, you know that they've done stuff, so you're kind of prepared, because otherwise you still can do it. I mean, I know we've been in each other's rooms where we go in and you're like, oh man, this patient must have had X, Y, and Z because it's wood. It's like dissecting through wood. But the thing is, you can do it, and it does take a level of experience, because if you don't have that experience, you could potentially create a tissue flap that's too thin and have a healing issue, or you could get into a structure you're not supposed to be in. But I've seen you go through all kinds of different terrain and territory, and it ends up working out. But it's really nice when it's like having a roadmap to what's going on like helps so much. Or when you go into someone who's had like multiple rounds of liposuctioning in the neck and then RF microneedling, whatever, it's like literally dissecting through wood. You can get through it, but it just sometimes we need to know, because we need to add an extra hour to the surgery or something, just so that you can go a little slower.
If someone's had radius in certain areas of the face or neck, I'm already like, okay, let me think about my approach. Maybe we do this preservation approach now, right? Where I go all the way, limit my skin dissection, and just go into the subsmass, subplatysma, and that way you just kind of bypass all that. And we're already doing so much of the subplatysmal dissection. It's not that much different of a surgery, honestly. And I've been doing that a lot in certain patients, trying to do the non-delamination kind of thing.
Right. So not having to open things up in the midline, correct?
Yeah. I mean, if it's indicated, it's indicated, but sure. Yeah, just trying to kind of keep the skin and the muscle together. Sometimes that actually gives you more snatch results, which has been really interesting.
Very interesting.
Yeah.
Let's throw the counter question. Yeah. Anything you would recommend ahead of time that you're like, oh, that actually makes things better or looks better?
Yeah. I mean, I think, so when you do surgery, often patients are like, I don't have to get Botox anymore, right? Like, we're good, right? And the answer is, of course not. I mean, I think Botox is amazing. Neurotoxins in general, I should say, are amazing adjuncts and tools that we can use, right? Helps with, obviously, wrinkle formation, and, helps with kind of smoothing things out in general. There's just things that surgery doesn't do well, right? We were just talking about, like, do you cut all the muscles in the eyelid to make things smoother? And, that's been described, but I don't generally think that's a great idea. So things like Botox and, your fillers, when they're used appropriately, which, like you said, in our med spas, like they do a good job of kind of keeping things, at a good natural spot. Sculptra, those are good products. to kind of consider as well. When they're placed appropriately, it's not that much of a problem, but it's good to tell your surgeon, obviously, like, yeah, I've done this a few times.
That's a great point, Rich. So patient gets a facelift,
Yep.
neck lift, maybe they get other stuff too. What should they do to maintain their results? Is there, and this is kind of dovetails into the neuromodulator discussion, but what's your regimen? Like, you're seeing them at 6 months, a year. What would you say? Hey, here's what you need to be doing. Here's how you make this last longer.
It's such a broad spectrum of people. In the ideal scenario for us, it starts with skincare. I think that's really the key thing, being on a good retinol, tretinoin, taking care of your skin with SPF products and your antioxidants, your vitamin C's, etc. And then, after that, it's kind of maintenance, neurotoxins. Like I said, if you need a little boost of volume here and there, you can always do fat grafting, fat transfer. Fat transfer is super popular these days.
Is that a down and out procedure? Get in general anesthesia, or can that be? How is that? Like, if someone's like, so I'm gonna have surgery again.
It can be either way. Some patients prefer to go to sleep, but today we did it today, and perfectly awake, well tolerated around the cheeks, tear trough area, and we spin it down, make sure it's nice and fine. The microfat, the nanofat, these are different tools. But yeah, I mean, in terms of maintenance, then we talk about lasers and. Certainly there's a role for things like Elocore for sure. I use it around the mouth a lot for kind of the lines around the mouth, combine that with CO2. That's been pretty nice for our patients and, trying to give them that whole, just rejuvenation, a total rejuvenation. But that does mean we need to take care of the skin at the same time. You can have no jowls, but for some people, they might have really bad sun exposure, just like leathery skin sometimes. So it's hard to kind of tell everybody, to be on the same regimen. Microneedling, also really good. Yeah, nothing wrong with microneedling. All skin types are fair game too, which is sweet.
Yeah, I did that the first time. It's good.
Well, I think you bring up a really good point. Some facelifts, it doesn't take care of some patients come in and they assume, hey, I'm getting a face and neck lift. They think it's going to cover all the stuff around the mouth, which is not. So, and perioral rejuvenation is a big deal. The signs of aging are huge in that area. And so we ultimately have to do these adjunct procedures to address those things, right? Like Elocore, microneedling, CO2 laser. You have to address it, otherwise they're going to have a really nice face and neck, but then they have all the signs of aging around their mouth.
Yeah, and with all the information that's out there too, there's certainly some patients who are like really anti certain procedures, and that can be tough too when that this is really the best thing for you. So really have to develop that relationship with the surgeon or the injector, whomever. Like, yes, it's okay sometimes to do fat grafting or sculpture or filler, whatever it is. There's a reason why they're really useful, and not to be afraid of that.
One thing I was just thinking about is, because today our topic is facelift, and you tell me. I mean, I feel like I get this a lot where patients come and say, "Doc, I want a facelift. I want a full facelift, or I don't want a full facelift." Can we talk about what it means? Just so we've really kind of, I think, discussed what a lower face and neck lift is. But talk to us about this part of the face. Cheek and up. Like, what does that mean when a patient says, "I want that kind of facelift"? Yeah. What does that mean, actual from a technical standpoint? And what procedures would that be? And could you do that with a lower face and neck lift?
Yeah, right. The full facelift. You're taking the brow traditionally as well, and sometimes that's like a complete incision across the forehead. In the hairline, I should say, and that's to kind of elevate the brow, the middle of the forehead as well. Sometimes you can manipulate the hairline as well. Obviously, position the brow as well. Okay.
So you mean lower the hairline, right?
Oh, sorry. Yeah, you can lower the hairline. You can also
cool.
take it up if you really wanted to, I guess. But some people do have a really, short forehead. But yeah, and then as you move down, you're kind of touching the mid-face area, and you certainly lift those areas as well. The temporal brow lift as well is a huge role these days. Brow aesthetics changes so much over time, and you really want to listen to the patients about what they want. But yes, a full facelift would include all these parts, the upper third, the middle third, the lower third of the face. And, I feel like these days, certainly when we, talk about facelifts, sometimes patients think it just kind of applies to the whole head, the whole forehead and everything else. And I do think most patients these days are thinking, okay, we're talking about the lower part of the face for the most part here. We're addressing the jowls as well. So, yeah, sometimes they think that, you know, it also includes the eyelids and things like that. So we kind of have to clarify that. But that's easy to kind of redirect people on that for sure.
Favorite approach for brow lift?
Ooh, endoscopic or temporal. Yeah. I you know, I think the trichophytic incision, the one in the hairline, is very powerful. It's just, it's certainly quite an incision to go, make.
General versus local, gentlemen. People going to sleep for this procedure, or can they do it awake? And what is your preferred approach? And what if somebody's like, hey, I just don't want to go to sleep. I want to hear it all.
Yeah. So my preferred approach is definitely general. I think it's the safest, most efficient for sure. We can certainly ensure the best possible result, in my opinion, as well. There are cases where I've done them with patients being awake too, for various reasons. If it's anesthesia, mainly being the main one, if they can't undergo general anesthesia. Sometimes if we're doing like a unilateral surgery for some reason, that might be fine too. But yeah, I mean, I think it's just much better. Modern anesthesia has made, huge improvements. There certainly are risks to general anesthesia, but I think that, we've got great people here work with us routinely. Like I said, anesthesiologists, CRNAs who work with us daily, right? And so huge amount of support in the OR, which is great at our practice. I've personally talked to patients who underwent a lot of procedures under local and have had discomfort and, maybe had results they didn't really like as much at other practices from doing it under local. So not to say you can't do it, but just know that that's the risk, that you can't get the result, that you maybe want just because you're uncomfortable, which, that's not worth it. This is your face. You want to make sure
Here's the deal. I would tell you that for me, it's very much patient driven. Like I can tell, like if I'm like, listen, if they're like, can you do this under local? I'm like, well, how do you do with things? Do needles bother you? Do you get queasy? Are you an antsy person? How are you going to do hearing sounds, vibrations, feeling things? Because you're going to feel those things. And I think if they're like, no, I'm good, and like I want to do it, and I will do, fairly decent facial procedures under local. I'm going to do full face and neck and do some lids, do other stuff. But the thing that it's super important is that patient has to be like fine and bought in and be able to get to a state of being calm. We still give them oral relaxation. We do it. But I agree with you, Rich, because one of the things that people don't realize is, so they'll say, well, how about Twilight, doc? Do Twilight on me. And what happens is, and I think Twilight, quote unquote, or these kind of total intravenous anesthesias, there are a lot of surgeons who do some of these things. They work out pretty well. But I'm going to tell you something. Having control of the airway is one of the safest, best things in my personal opinion.
I don't think you should do anesthesia without a controlled airway.
It's like you can choke. Patients can choke and have
it's all
aspiration.
considered, even the sedation stuff people talk about, right? It's all considered general anesthesia.
Yeah.
That's the thing.
And it's either whether or not you have a protected airway or you don't.
Right.
And for us, it's like, hey, you got to have a protected airway.
Yeah.
But I think it can be done well with it, but it's like patient selection. And I'll be honest with you, most patients don't want it. Most patients want to have a good experience. They want to be comfortable. They don't want to feel things. And also, like as a surgeon, like you want to be comfortable too, right? And if someone's really chatty, it can sometimes be a little bit of a micro nuisance, not a big one. And then the other is like, if there's something happening, you're worrying, you're doing stuff, like you don't want to get a patient all nervous either. Like you just want everybody to be calm. So I think it's just, it's like everything that we do. You don't do the same thing on 3 patients that come in. Every one of them has something different, right? Yeah. I mean, it just is what it is.
Yeah.
Shifting gears to male facelifts. Let's talk about some of the nuances. Dr. Cal, what some of those nuances for you, and then specifically, let's talk about a direct neck lift for guys who don't want the traditional approach.
Yeah, men are definitely getting facelifts more and more these days. Many of them, don't like to share their photos. It's been certainly a challenge.
Super annoying.
But they, at the same time, they heal great. Especially most of our population, they're able to have some level of bearded skin, which really helps. Me, not so much. But when they're healing in the hair area, that heals super nice. I try to line up their sideburns nicely, okay, and they're able to carry that up. I typically will make a pre-tracheal incision, which kind of goes in front of the ear it heals great because again, you're bringing that hair into the area. And also, technically you don't want to bring that hair into the ear canal for what it's worth. But other than that, men are bigger. They have bigger heads, bigger vessels. Maybe they have a little bit higher risk of bleeding. So important to kind of be prepared for that. Doesn't really change anything technically
But
during
approach
surgery.
is the same.
Approach is largely the same. I think men are usually looking at specific things that they want to adjust. And that's usually, for me, the procedures are either the eyelids, so usually where they start, or in the jowls and the neck, right? So those are kind of the two main things. So yeah, I mean, everybody has different tastes. Maybe they're thinking about the hollowing around their eyes as well. So, think about volume. I kind of changed it up a little bit based on everyone's anatomy. Men often have a more square jaw, so you're thinking about the way you're going to lift. The vectors are a little bit different just to get a nice jawline, which is what I think men are largely looking for. Yeah.
The nice thing for men is that it definitely is something that is a masculinizing procedure. Like there's nothing about it that feminizes them. Like, so a male getting facial restoration, like lower face and neck lift, or eyelid surgery, or fat transfer too. Sometimes you tell them, hey, I'm gonna need to add a little volume, and they'll kind of look at you sometimes. But the truth is, almost every man has infraorbital hollowing, has a little bit of cheek loss, and so when you restore that and combine that with upper lid, lower lid, the effect is so powerful. I mean, these guys come back and I would say some of them are like even more impacted than their female counterparts, because they're just like, man, all right, I'm here. And there's guys who are working longer. They're in big positions, or they're competing with younger guys for position, and women are too. But I get this more from guys. Hey, doc, I gotta be able to compete. Yeah. I gotta be able to look. I want to look as good as I feel, and it's crazy what you can get with them. And what you're saying is really interesting. When they heal, the scars are almost invisible, and it's because they got this ruddy pilosebaceous skin. So it's like, I mean, you've done it. I know I've done it. I think you have too. Like even guys who wear their hair real short, i.e., bald patients, will do this all day long, because the change is so significant. And even after things heal up, the scars actually are not super visible. So it's a pretty remarkable thing for guys.
Yeah. And I think a lot of men, they, to talk about the fat transfer aspect, they definitely don't like the concept of it, because they're like, I don't want to look fat, I don't really need to take that from my belly and put it up there. But yeah, you're absolutely right. Especially with the eyes, they are always kind of surprised, like, oh my gosh, that was the best thing. And most men haven't maybe played around with fillers and things like that, so they don't really know what the role is of volume in their surgery. So that's why it's huge to kind of talk about that. Direct neck lift, though, certainly an option for people that
who is that ideal candidate for the?
Yeah. So the ideal candidate for that, someone that you're largely looking at just problems with the neck. We're talking underneath the mandible itself, just in the area underneath that area, instead of addressing the jowls. Maybe they don't care for it. Maybe they can't really have, maybe they can't have like.
I mean, the last few that I did were individuals who said, Doc, I'm not going to sleep. I'm not doing general anesthesia. This is the only thing that bothers me. Or they have medical issues that, prohibits them from doing general anesthesia. And they're like, just take care of this. And they're all happy.
Yeah. And some subtleties on that. Yeah. I just actually saw a patient who I did this on, especially if they just have really good anatomy for one, but if it really is largely just skin and it's pretty high up, you can actually carve a really nice angle, certainly better than, and honestly, in traditional approach sometimes. It is under local.
What's the biggest drawback?
Scar.
That's the deal.
The scar runs, we try to make it irregular purposefully, so you're not, your eye isn't drawn to that linear scar. You don't want scar strictures.
You kind of put a little Zorro in there.
Kind of put a little Z in there. The Grecian urn. Shout out to the Greeks. But
we invented a lot of things, including direct neck lifts.
Urns.
Yeah, you guys are urn specialists.
So yeah, I mean, it's a great procedure for the, especially for men for the most part. I tend not to offer it to females. I don't know about
I can only count like one that I've done on a female.
Yeah. Does she have some facial hair to help out?
Unfortunately, she did not, and so that's the thing.
Yeah,
she had redness. She had a little bit of thickening. So sometimes that's the biggest thing of that thing is you just need to be prepared for some TLC, but it is a good option. It's really remarkable. I mean, like direct interventions. I mean, what's your thought on some of these other direct surgery, like direct central lip lift or direct lateral lip, direct brow?
Doing a lot more lip lifts now. It's obviously very popular surgery. I think there's a lot of nuance in it personally. You want to look at the whole face. So you want to look at the length, obviously, of the upper cutaneous lip, which is from the area underneath your nose to the top of the vermilion, right? And that can
is
be
the red part, right?
yeah, especially the junction of the red to the lip roll, and that's the kind of the area that you're measuring to see if it's long or not. But I asked them a bunch of questions, like, has this changed over time? Have you lost weight? What about your teeth? The role of the structure.
That's a great point.
that,
The teeth, because sometimes they want that dental show, and the lip
Yeah.
lift is actually not the thing that's actually correcting that. They need to have their teeth worked on.
Huge. And
Great
then also
point.
loss of bony volume, obviously in the mid face area, that contributes to it as well. And so people feel like, oh, maybe I look frowny. Maybe it's coming with the corners being the issue as well. So, and then I asked about their teeth. Do you like your teeth? Do you feel like you see a lot of your teeth already when you smile? And if the answer is, yeah, I see like too much of it, that can be a tricky surgery to do. It doesn't mean you can't do it, even though you have a long upper lip. But I really take the whole facial balance into the central lip lift because it's a very powerful procedure for what it is. It's such a small piece of tissue, and you're taking millimeters out, but it's just kind of takes everything out and puts in different proportion.
Pro or con buccal fat removal?
Oh,
Pro.
I'm pro. So especially in the facelift, when I am in deep plane, I'm able to pluck that out. It's huge to decompress it. Some people are doing.
So what
things
are
like,
patients going to see when that it gets removed?
Yeah, often the buccal fat has kind of descended, and the tissues
Sometimes
around.
it ends up down here in the jowl.
Exactly, in the jowl area here, and it kind of, especially in these ladies with really thin skin, you can almost like see it pop out. And you test it beforehand during surgery, make sure you're seeing what you're seeing. But yes, decompressing that area is going to help not drag down the jowl, especially post-operatively. So you can definitely tell a difference.
Yeah. And
In a younger patient, there's also some indications for buccal fat removal.
Yeah.
Reduction,
So that's a great question. I think it's super. You hear some people saying, "I would never ever do a buccal fat removal," blah blah blah, just taking this stance. And then you have others. No one really says I'll do it on everybody, but I think it's got to be a unique patient to patient thing. But let me ask you this: so when you're doing a buccal fat removal on a young person, what's your approach? Because just because you're doing a buccal fat removal doesn't mean you have to take out every ounce of buccal fat. You can do a buccal fat reduction. And I feel like that's what we actually are doing for these younger patients. You're keeping the volume. Yeah. So honestly, walk us through that. Just what's your position on it? And what do you think about people say you never, ever take somebody's buccal fat because you'll pay for it in the future? I'm wondering, what are they talking about? What are you going to pay for?
Yeah. I mean, patient selection is key here. If you have someone who's really wide, cheeky, just really kind of puffy here, they're just a little bit rounder, and you're just trying to help them out, trying to give them a little bit of a carving out for their cheek, their jawline. And I think people are just trying to say something that doesn't really make sense.
Have you ever had a single patient, because we've all done a lot, I can tell you, all of us have done a lot. Have you ever had a single patient unhappy with the removal?
None.
Not a single one.
I've had one or two say, we should take a little more. It seems like there's a little asymmetry here.
But never has it been, you took too much.
No. And like not someone say, hey, I need volume put back in.
By the time someone has noticed that buccal fat was gone, let's say you give them 30 years from now, I mean, that's really not going to change.
It's actually not gone. It's just descended. It's still there. And it's down
largely
here.
just, but like if you took it out, it's probably just normal skin, muscle, etc. So that's, it's hard to know exactly why, it was trending that, you shouldn't do buccal fat ever, because I do it all the time. It
just shows you we have so much to talk to our friend Dr. Cal here about.
This has been an amazing conversation. I can't wait till the next one. We're gonna spend a lot of time talking about noses, because Cal knows the nose. This has been incredible.
Talk about ears too. I mean, he does a lot of otoplasties too, just noses and faces. But
he does thighs also.
Eyes and thighs.
Thighs and eyes.
But in all sincerity, this has been a great episode. I think that we want to thank all our viewers for watching and listening. And any questions or thoughts you have for us and Dr. Cal specifically, please reach out to us on our platform and submit any questions or any other things you want us to talk about next time.
Thanks, guys.
Awesome.
Appreciate it.
Thank you for listening to HKB Uncut. If you enjoyed this episode, please subscribe to us on Apple, Spotify, or YouTube.
To book a surgery consultation or med spa appointment with our team, visit our website at hkbsurgery.com or head to the links in our show notes.